Professor Pragati ma'am, Professor Ashna ma'am, esteemed faculty, colleagues and dear students. On behalf of the Department of ENT at AIIMS Raebareli, I would like to welcome you all to this neuro-otology workshop. Today we share a common goal to understand the complexities of the vestibular and auditory nervous system. This workshop shall play a crucial role in bridging theory with practice. Over the course of this event, we will engage in discussions, hands-on demonstrations, case-based learning and interactions that we hope will spark new ideas, collaborations and clinical confidence in everyone. I would like to extend a special welcome to our invited experts and faculty who have joined us. Your expertise, mentorship and willingness to share insights enrich this workshop immensely. We hope the sessions ahead are intellectually stimulating, clinically relevant and professionally rewarding. Once again, welcome and we look forward to an engaging and productive day together. Thank you.
Ma'am, to commence the event. To seek the blessings of God, I would like to diligently request all the faculty.
Such workshops, which are small group focus workshops, are frequently being held. ENT, which now they want to call Otorhinolaryngology, has come forward with a workshop on vestibular diseases. These are common problems which all of us face in lifetime. At least once, if you survive by 60 years, at least once you will be facing the problem. And these are common problems we have to understand, and there is more than simple ear which is involved. So there is nervous system's involvement also, and I am very, very pleased to see that both the departments together are taking this forward. I am not an ENT specialist, so I am really not familiar with what the intricacies of this disease is, but what I understand is that these are common diseases and infections. They need to be diagnosed appropriately and managed appropriately. The technology has helped and is advancing day by day, so we have better tools for diagnosis as well as for management. I congratulate organizers for this thoughtful workshop, and I am sure that I can see that people might be coming, and winters have started, so early morning sessions might be a little thin. But what I am seeing is a full hall, if not full hall, more people here. And I hope this is going to be a useful workshop for all of you. Thank you very much.
Thank you, ma'am, for enlightening. To a patient with vertigo, I humbly request Dr. Arijit Jodhar sir to come on stage. Sir is Associate Professor in Department of Otorhinolaryngology and Head Neck Surgery at AIIMS Raebareli and has multiple index publications and multiple funded research projects.
Jodhar, and today my topic of presentation is approach to a vertiginous patient. So in this topic I'll cover the basics of the vestibular system in brief, the vertigo versus dizziness, the types of vertigo, approach to vertigo, and final tips and takeaways. So what is a vestibular system? It is basically part of our inner ear that deals with the balance. It comprises of, the vestibular system comprises of the utricle, the saccule and 3 semicircular canals, as we all know. The 3 semicircular canals, there is a posterior semicircular canal, a lateral semicircular canal and a superior semicircular canal, and the posterior ends of the superior and posterior semicircular canals, they form a crus communis that open into the utricle. So the utricle and saccule, these are also known as the otolithic organs. They are responsible for the linear motion and the head tilt, whereas the three semicircular canals, these are responsible for the rotational accelerations. There are other two structures, one is the sensory hair cells and the dark cells also in the vestibule. So what is the function of the vestibular system? It basically generates information and projects it to the central nervous system for, first is the gaze stabilization, second is to enable the balanced locomotion and body position, third is to provide general orientation of the body with respect to the gravity, and fourth is to readjust the autonomic functions, that is, whenever the position of the body changes, the autonomic functions they readjust. So what are the central projections? The central projections of the vestibular system, most important is the vestibulo-ocular reflex that ensures our gaze stabilization, and second is the vestibular spinal or vestibular colic reflex that actually maintains our upright posture and the head stability when the position of the body changes. Along with it, there is the vestibular cortex and navigation that causes the perception of self position and spatial orientation, also the autonomic adjustments. So what is vestibulo-ocular reflex? It actually enables the stable vision whenever the head position changes. So even if the head position changes, the focus, the gaze remains intact so that the balance is maintained. So it has obviously, like any reflexes, it has an afferent pathway, an efferent pathway, and a central relay system. So it starts from the vestibular nerve, from the semicircular canals, utricle and saccule, and then it relays into the vestibular nucleus. From there, the connections, they go into the oculomotor and the abducens nucleus, and ultimately that affects the extraocular muscles in forms of the extraocular muscle movements to maintain the vestibulo-ocular reflex. There are two terms, one is RALP, one is LAR. RALP is, that means the semicircular canals, they act synergistically in push-pull mechanism. That is, LARP is left anterior, right posterior, RALP is right anterior, left posterior. That is, the left anterior semicircular canal and right posterior semicircular canal, they act in push-pull mechanism. That is, when one is stimulated, other one is inhibited, and the vice versa. And same for the two lateral semicircular canals. So when one lateral semicircular canals are stimulated, then ipsilateral medial rectus and contralateral lateral rectus are stimulated. For anterior semicircular canal, it is the ipsilateral superior rectus and contralateral inferior oblique, and for posterior semicircular canal, it is the inferior superior oblique and contralateral inferior rectus. Now coming to the part of definitions. That is, now the question is, what is a vertigo? Are the vertigo and dizziness are the same? Well, the Bereni Society has given the International Classification of Vestibular Disorders in January 2009, and they released the first consensus document of Committee for Classification of Vestibular Disorders in 2009. According to that, vertigo is a sensation of self-motion when actually no self-motion is happening. That is, it is a virtual orientation. That is, the patient is having a sensation of self-motion, but there is no self-motion. In contrast, dizziness is the disturbed sense of spatial orientation. That is, it is basically a sensation of a distorted spatial orientation. It is not that it is a distorted sense of self-motion. So these two are different, and this is clearly stated in the Bereni Society consensus statement. Now, what are the vertigo types? These symptoms are classified into four types. One is vertigo, one is dizziness, one is vestibular visual symptoms, one is postural symptoms. The vertigo again is of two types, spontaneous and triggered. Triggered means with some triggers the vertigo is elicited, and for dizziness also it is the spontaneous and triggered. Now, what are the triggers? It may be Positional, that is the change of the position of the body. It may be due to change of the head motion. It may be due to visually induced, due to sound induced, due to valsalva induced, and due to orthostatic. Now the big question, this was the practical question is how to approach this. Well, the clinical history and examination still plays the pivotal role in approaching a vertigo patient. So a simpler approach was given by that included the first letters of some different parameters. That is, S is symptoms, O is often, S is since, T is trigger, O is otology, N is neurology, E is evolution, and D is duration. So first is, what are the symptoms? First is, so when we take the clinical history, these are the questions that we have to ask the patient, and we have to elicit this history from the patient. That is, what are the symptoms? Is it vertigo, dizziness, nausea, postural instability, fall with or without syncope, rotatory or linear sensations, tilt of the vertical and oscillopsia. Then, how often does it happen? Is it daily, weekly, monthly, irregularly, continuously? Then, since when does the patient suffer from these symptoms? Is it a week? Is it for months? Is it for years? Then, what are the triggers? Very important. Aggravating factors. Whether there is a change of the head position, change in the, whether bending in the bed, that is typically important for the positional vertigos. Then coughing, noise, visual stimuli, all these can act as the triggers. Then otological symptoms, whether there is a hearing loss present or not. In labyrinthitis, obviously hearing loss is present. In the tinnitus may also be present. In Meniere's disease, tinnitus is present. Oral fullness, hyperacusis, autophonia, before, during, or after the discharge, the attacks. So these otological symptoms may or may not be there, and that also actually influences the final diagnosis. Then neurological symptoms, very important. Whether there is headache, migraine, face or limb paresthesia, any facial weakness, any facial paralysis, all these are important. That may indicate towards a stroke. Then evolution, that is whether it is persistent, improving or worsening, whether there is any ups and downs. And lastly, duration, whether it stays for seconds, minutes, hours or days, or it is continuous. So they have given the difference. So they have classified the vertigo into three types. One is acute vertigo, one is episodic vertigo, and one is chronic vertigo. So for episodic vertigo, for acute vertigo, usually the difference is between some central disorders and some peripheral disorders. The central disorders are usually in the forms of stroke, and the peripheral disorders are in the forms of either vestibular neuritis or labyrinthitis. Now, how to differentiate? Main point is the otological and neurological symptoms. Between vestibular neuritis and labyrinthitis, the labyrinthitis patients, they suffer from hearing loss, but not the vestibular neuritis patients. Similarly, in case of stroke, if we want to differentiate between the stroke and vestibular neuritis, the stroke patient will have neurological symptoms like cerebral symptoms, ataxia, and up the distorted gait, but these will not be present in case of vestibular neuritis or labyrinthitis. For episodic vertigo, there are multiple diseases. I think some of the modules are on these the diseases actually today. So one is BPPV, that is a benign paroxysmal positional vertigo, Meniere's disease, and vestibular migraine. Important is BPPV. The trigger is very important here. The position changes ultimately elicits the vertigo in case of BPPV. And in case of Meniere's disease, here the patient suffers from hearing loss, but that is not present in the BPPV. And neurological symptoms will be present in case of vestibular migraine, but not in case of BPPV or Meniere's disease. And chronic vertigo usually contains two diseases. One is persistent postural perceptual dizziness and the bilateral vestibulopathy. The bilateral vestibulopathy usually occurs continuously, and in case of PPPV, usually it is accompanied by panic attacks. So coming to the last part, that is the examination. Here I will focus on the examination of the acute vestibular syndrome. Now, what is acute vestibular syndrome? It is the acute and persistent vertigo. That is, the symptoms are going on continuously and patient is suffering from it for quite a long time. So, if such a patient comes to us, the first question is whether it is central or peripheral. First thing that we have to determine. So, to find the solution, David Newman-Tucker in 2009 coined a type of examination that is called HINTS. What is HINTS? It is actually three tests. One is head impulse test, one is nystagmus, one is test of skew. So, how we do it, that I'll just demonstrate. But first, the interpretation. In case of peripheral vertigo, the head impulse test will be abnormal. That is, vestibulo-ocular reflex will be involved or affected. But for central vertigo, usually it has an intact viewer. Nystagmus, for peripheral vertigo, it is horizontal unidirectional, and for central vertigo, it is horizontal bidirectional, vertical, rotatory, anything may happen. And test of skew, it is usually a pathognomonic of central vertigo, usually not present in the peripheral vertigo. So, HINTS contains three things, 3 points. One is head impulse test, one is nystagmus, one is test of skew. Here, this is a patient. This is a sudden jerky movement. First, we have to hold the head of the patient and then we have to give a sudden jerky movement to the head to see whether the gaze fixation is there or not, or whether there is any catch-up saccade or not. As we can see, this patient do not have any catch-up saccade. But look at this patient. Did you see the catch-up saccade? Yes. So this patient, when we moved the head towards the right, the patient had a catch-up saccade. So the viewer is abnormal. So patient may be having a peripheral disease. Next is the nystagmus, test of nystagmus. Here, some patients may have spontaneous nystagmus and some patients may have triggered nystagmus. See, this patient do not have any nystagmus, but you can put a white paper on one side of the head and you can just test for the nystagmus. Lastly, test of skew. It is basically pathognomonic of the central disease where you alternately cover and uncover one eye and see whether there is any vertical skew, vertical movement of the eyeball on the opposite side. So this is particularly important for the central diseases. Now another problem. Even if the hints indicates towards a central disease, there are some diseases, some central causes of vertigo that may cause hearing loss. One such disease is anterior inferior cerebellar artery stroke. It is a direct branch of the basilar artery that gives rise to the labyrinthine artery. So if stroke involves this territory, the anterior inferior cerebellar artery, sometimes there may be hearing loss. So if hearing loss is there, then how to approach such patients? So again, Newman-Tucker and the scientists, they coined the point that is called HINTS plus. So what is the plus? It is basically, instead of HINTS, they suggested we add the new onset hearing loss with this. That is the hearing test, a bedside hearing test. So how we do it? We just do a finger scratch test in front of the ear of the patient. So it is a bedside test and we ask the patient whether he or she can hear it equally on both sides or not. So that is HINTS plus. So this is added and this helps us differentiating between ICA stroke also. So finally, to again focus on the central and peripheral parts, the peripheral causes of vertigo, of the acute vestibular syndrome actually, the peripheral vertigo will have unidirectional nystagmus, there will be no skew, there will be abnormal vestibulo-ocular reflex, that is abnormal head impulse test, and there won't be any acute hearing loss. But for central causes of acute vestibular syndrome, like in stroke, it will have a bilateral it may have a bidirectional or vertical rotatory nystagmus, the skew will be present, it will have an intact vestibulo-ocular reflex, and there may be acute hearing loss or new onset hearing loss. Now the last question is, when to perform hints? Should we perform in case of episodic vertigo? Should we perform it in BPPV? Answer is no, because in BPPV it is an episodic disease, episodic vertigo, and the symptoms are not persistent. Hints will only act, hints will be helpful only those patients who have a persistent or continuous sense of vertigo. So hints will not be the answer for BPPV. So final tips: whenever the patient with vertiginous symptoms comes in the ED, first ascertain whether it is vertigo or not. Then we can follow the source-to-node approach to find out the probable cause of the or probable origin of the vertigo. Then we can perform hints or hints plus examination to ascertain whether the acute vestibular syndrome is central or peripheral. And last but not the least, after that we can treat the patient accordingly. So thank you all.
In approaching vertigo, I request our chairperson, Dr. Archana ma'am, to felicitate Dr. Arijit sir with a token of appreciation. Neeraj Kumari ma'am, and to facilitate her, I'd like to request Dr. Ananya ma'am and Dr. Arijit sir to present the token of gratitude to respected dean ma'am.
Vertigo to be a migraine case in 90 cases. They did so by careful clinical exclusion of relevant diagnosis like other causes like migraine, Meniere's disease, TIA. So coming to the pathophysiology of vestibular migraine. The pathophysiology is very complex and poorly understood. But the most appropriate pathophysiology which is accepted includes that in migraine cases there is some abnormal sensitization of brain that leads to thalamocortical processing dysmodulation. Now this dysmodulation leads to migraine features, and associated with this there is a trigeminal-vesicular reflex which leads to dilatation of the labyrinthine vasculature. And due to that dilatation, we have vestibular dysfunction associated with the migraine features. So what do we know till now? That vestibular migraine is more common in females, perimenopausal age group, and they usually have a family history of migraine or an associated history of migrainous headaches. So why do we miss it? Because vertigo may or may not be associated with headache. Patients usually come with a history of vertigo. They miss a history. The history of vertigo, which may not be associated with the episodes of vertigo. They may be present before the vertigo or after vertigo. Second thing is that headache may not be associated with aura, which is a typical feature of migraine. So for diagnosing vestibular migraine, a thorough history of headache is very important. So usually when we ask the patients, they frequently describe headache as pain or pressure in different areas, including skull, trigeminal branches, occipital region, and even neck. So how to diagnose vestibular migraine? So diagnosis includes a detailed history. It includes at least 5 episodes of vestibular symptoms, which are moderate to severe intensity, lasting 5 minutes to 72 hours. So the duration of vertigo is very vast. It may be from 5 minutes to 72 hours. So what do you mean by moderate to severe intensity? Moderate intensity vestibular symptoms includes when the patient has vestibular symptoms, but that does not hamper his daily activities. But severe intensity vertigo is that patient's daily activities are hampered. So at least 5 episodes history is required to diagnose it as a case of vestibular migraine. The second point is there should be a current or previous history of migraine. It may or may not be associated with aura. Third point is that 50% of the vestibular episodes should be associated with migrainous features. Now, what are these migrainous features? There are 3 points in that. First is headache. Now, headache should have 2 qualities. First, it should be unilateral, pulsating in nature, moderate to severe intensity pain, and it is aggravated by routine physical activity. Second point is photophobia and phonophobia. So phonophobia is sound pressure induced vertigo. Then visual aura. Visual aura is the patient may have a feature of light zigzag lines in front of the eye, or either a scotoma that makes reading difficult. And the fourth point is that vertigo is not better accounted by any other vestibular diagnosis. The other thing is probable vestibular migraine. When we don't have all the features, then we define it as probable vestibular migraine. It includes the first point, that is at least 5 episodes of vestibular symptoms, moderate to severe in intensity, lasting anywhere from 5 minutes to 72 hours. Second is either B or C criteria. B is associated migraine headache or migrainous features during the episodes. And C is that it is not better counted by any other vestibular diagnosis. So how does the vertigo of vestibular migraine presents? It can present as spontaneous vertigo. It could be internal type or external type. The internal type is when the patient has a sensation of rotation of self. External vertigo when the patients report sensation of rotation of the surroundings. Other is visually induced vertigo. Any complex visual stimuli may induce vertigo. Then positional vertigo. That is induced by a particular position change. Then head motion induced vertigo or dizziness. That occurs during head motion. All other forms of dizziness imbalances are excluded from this criteria. The point to be noted that 38% of the vestibular migraine patients may present with auditory symptoms also, like tinnitus, hearing loss, oral fullness. So coming to the next is nystagmus. Nystagmus is rare to be found in vestibular migraine. Reason behind is that most of the patients don't come at the time of attack. If anyhow they come at the time of attack, you can find nystagmus. Now nystagmus is gaze-induced nystagmus, central positional nystagmus, horizontal or vertical spontaneous nystagmus. So the Barony Society position paper on cervical dizziness, this is a good article. It states that vestibular migraine is by far the commonest cause for combination of neck pain and vestibular symptoms. Here I want to say that head movements usually aggravates any vestibular condition. So a common finding which we encounter in vestibular patients of increased muscle tension that can be the cause or the effect of reduced head movements, because the patient wants to keep his head still. Now this leads to increased muscle tension. So this can be found in all patients of vestibular conditions. So what are the relevant differential diagnoses? The relevant differential diagnosis includes BPPV, vestibular neuritis, Meniere's, posterior circulation, TIA and posterior circulation, CVA. So we have to exclude all these one by one. So how will you differentiate between a vestibular migraine and Meniere's disease? So one common finding is that auditory findings of worsening hearing loss helps to differentiate vestibular migraine from Meniere's, because Meniere's frequently shows progression of hearing loss to profound levels, while vestibular migraine does not. Patient with Meniere's may show a reduced caloric response and a normal VHIT. So a dissociation between these two, there is a normal VHIT but reduced caloric response. This goes more in favor of Meniere's disease. Vestibular migraine may also mimic BPPV. That is because of the occurrence of positional vertigo. To differentiate, we have to look for the positional nystagmus. The positional nystagmus in vestibular migraine might not fatigue, whereas in BPPV it is usually fatigable. And the typical torsional geotropic nystagmus is seen in BPPV, not in vestibular migraine. The second point is that positioning maneuvers might not work in cases with vestibular migraine. Another important differential diagnosis is transient ischemic attacks or posterior circulation CVA. So in any patients with 1 to 2 episodes in recent times, we should consider risk factors like age more than 60 years, diabetes, hypertension, any focal neurological symptom at the time of episode, and we should evaluate him further for TIA. So if a patient comes who is elderly, age more than 80 years, any of the risk factors like she is hypertensive and she has a recent history of only 1 to 2 episodes of vertigo. So we should evaluate we should have elicit a more detailed history to rule out any focal neurological symptom at the time of episode, and should evaluate, first in a previous lecture, it is useful in acute continuous vestibular syndrome. So in any patient who presents with acute continuous vestibular syndrome, we have to use hints to rule out central cause. So there is no diagnostic bedside test or imaging to diagnose vestibular migraine. So what is the role of VNG in vestibular migraine? VNG might help us to rule out other peripheral causes, like reduced caloric response is usually seen with peripheral vestibular loss, vestibular neuritis and labyrinthitis, and VHIT may help to differentiate these from vestibular migraine. So how will you treat a patient of vestibular migraine? So usually the treatment is in the line of migraine. So the manner you treat migraine, vestibular migraine should be treated similarly. Acute treatment can be treated with zolmitriptan and ergotamines. A short course of prochlorperazine might alleviate the symptoms. Prophylaxis of migraine headache initially started with propranolol and flunarizine. If patient not responding, we can use antidepressant amitriptyline or anticonvulsant lamotrigine. Vestibular rehabilitation exercises should be tried in all patients of vestibular disorders. Another thing is patient has to be counseled regarding migraine triggers. There could be numerous triggers. We have to elicit the triggers from a proper history. These include foods like fried, fatty food, coloring agents, tea, coffee, beverages containing alcohol, daily life pattern, any change in the daily life pattern like reduced sleep, dehydration, exhaustion, lack of sleep and lack of hunger, changes in sleep pattern, emotional stress, weather changes, anything could act as migraine triggers. And hormonal changes during the time of menstruation, these all act as migraine triggers. So I want to present an example here. This is a 61-year-old female who presented to us with a rotatory sensation for 1.5 years. She has almost daily episode which lasts for 5 to 10 minutes. Vertigo is position and associated with nausea, tinnitus and unilateral headache. There was no history of reduced hearing loss, though you can see there is a dip in at 4000 and 8000 kilohertz frequencies. On caloric testing, you can see in this butterfly chart, the central point is within the box. So, depicting there was no canal paresis. On gaze-induced nystagmus, patient has nystagmus on rightward gaze. You can see a horizontal nystagmus on right gaze. So the nystagmus here was not fatigable, pointing towards a central cause. Caloric response was normal, which might rule out a peripheral cause. So we diagnosed this case as a case of vestibular migraine and was treated using migrainous treatment for migraine headache, and patient responded well to the treatment. So coming to the conclusion, vestibular migraine is a common cause of vertigo. 5 or more episodes of vertigo, half of which have a migrainous symptom associated with them. Vestibular migraine can cause minutes to hours to days of vertigo without headache, and don't make a diagnosis unless multiple episodes over a significant time period. Be very careful in elderly with risk of TIA and only 1 to 2 episodes in recent past, and treatment should be like migraine headache. Thank you.
To salutate Dr. Ananya ma'am with the perquisite, I request the chairperson, Dr. Prakriti Garg ma'am, to come forward. Thank you, ma'am. Head of Department of Head and Neck Surgery at SGPGIM areas of interest.
Vestibular migraine is one of the commonest mimicker of any vertigo syndromes. So I have seen the patient has typical complaint of the PPV, and you test for all some attack of this vertigo because it is one of the most common symptoms somebody presents. So I had a history of migraine myself, and then at one fine day I felt dizzy in the morning. And Saturday night, I had a headache and I took our usual, and in the morning I felt. So I thought it's a vestibular neuronitis, it is just developing, and I was swaying. I was swaying on under the test, right? So I thought it's okay, it's maybe that developing, right? So then after rounds and all that, I didn't went to OT, I go home, slept. And in the morning I was absolutely fine, right? So in the evening I was absolutely fine after 3-4 hours of sleep, and then at that time felt that okay, although all definitions say, recently one of the professor was visiting ZPGI for one of the exams, and he suddenly started having vertigo, right? And he was quite concerned, went to neurology, did an MRI, right? And then I took the history, I examined and all that, and I said this may be your, if you have a history of migraine. He has a severe migraine, he was having a headache on the back side with the neck pain, and along with that vertigo. And then next morning he was still there because the exam was 2 days of anesthesia. Then he told me in the morning that he is fine now. So I just want to highlight that the first episode of any patient who is suffering from migraine, the vestibular migraine, first episode is typically you will diagnose of something else, because he has not suffered the 4-5 episode. And once the patient knows, so coming to the topic, okay. So acute unilateral vestibular failure, what is the common vertigo syndrome? So you can have acute unilateral vestibular failure, unilateral recurrent vestibular syndrome, which may be either BBB or Meniere's. In acute unilateral vestibular failure, you have vestibular neuronitis, bilateral vestibulopathy usually in old age, or when the Meniere's patient had suffered for 15-20 years, the other ear is involved, and now slowly the glory goes down. Then we have central vertigo syndrome, that is a vestibular migraine is one of the perfect example of that. Along with that, there may be some neurological causes, cerebellum or TIA or some vascular event, and then we have PPD. So we will try to see that how these cases intermingle. This is the long chart but what I want to mention here is, So what do I mention here is that the autonomous nervous system, so you can see the line below, the autonomous nervous system is very, very definite, and so that's why the peripheral vertigo patient will have a lot of nausea, vomiting. So this you can see that autonomous nervous system. So this is very, very prominent in patient of peripheral vertigo, and if you have diagnosed this, and this is less definite or absent, most of the time it's absent. So autonomic nervous system leads to nausea, vomiting and other things. So I will come to a case, a 58-year-old patient, known case of cardiovascular disease, underwent angiography 5 years back. Present in emergency early morning 5 am with severe vertigo, vomiting, palpitations, sweating since last 2 hours with elevated BP. So anybody who would have autonomic symptoms will have all these things, and it comes into emergency with sense of impending doom. So what do we diagnose? A patient of CVA. So it was diagnosed that he is having a CV attack again. The patient has similar complaint in the past, but there was no vertigo. When the patient first got this kind of heart attack, or whatever for this he has done in geography. It was a nearly similar episode with only vertigo and nausea was not there. The patient related thought that the repeat attack of severe. The patient was admitted to the medical ICU. His BP was elevated, but ECG came back as normal, and trop I, trop T was done, and it was normal. So, what do we expect? So this is important that we take a good history, and this is a case of actually vestibular neuritis, which the patient suffered early morning, sudden onset, severe vertigo. But he was so anxious, and in his mind and in his caretaker mind, and even in the clinician mind, right? So many a times, every month we get 1 or 2 patients who are admitted in MICU with ECG with all monitors, right? And with some elevated BP because they have previous history of some hypertension and all that, and they all understand that this is a heart attack. So this is important that when you examine this patient, you have to keep the history in mind, trop T, trop I, sometime to be repeated after 24 hours if you have a lot of this, and especially if the patient has diabetic, they do not have any chest pain. So these can mimic as vestibular neuritis, can mimic as, and bedside test can be done easily. You will have nystagmus. The management is you do vestibular sedatives. So what happened in acute vestibular syndrome is that both the neurons are firing. Maybe you can understand that 120 is the firing, and suddenly if one side of vestibular system become weak, there is a message to the brain that the vestibular system is not functioning. The things are moving around. So start feeling, the patient start feeling the vertigo. But it takes 72 hours for the vestibular clamp to happen. So vestibular clamp will do the normal side vestibule will come down to a level, and it will then help you. So for 72 hours you need to give this patient acute vestibular sedative for the vestibular sedatives in the form of propionate or whatever it is done. And role of CMRI, there is no role of CMRI. When you are clinically diagnosed a patient, you have done a hint examination, you can do hint plus. But many a time if the patient goes is referred to neurologist, so sometimes the MRI is done. And then is there option to play the videos? Okay. Can you play from there? This video. Yeah, next one. You can, the Romberg is there. No, next one. No, the next, on the next slide. Next slide, please. Yeah, and just play this video. So, this is a test which can be done at the bedside. There are couple to prevent fall, right? And on the side, the patient is on the side of the lesion in acute vestibular syndromes. And even if the patient has been in periphery, so they are admitted, most of the time they are admitted, there's such severe nausea, vertigo, vomiting, they are pretty, so they are admitted. So even if they come to you 5 days or 7 days later with acute vestibular symptoms, that the dizziness will be lesser, but the imbalance will be there. And these patients benefit from vestibular rehabilitation therapy if explained well. And you can also monitor the progress with this thing. And also you can do a caloric test. There is no head impulse test. I think we can. I will discuss cases because we are already late. A 45-year-old patient presents with rotatory vertigo lasting for 1 to 2 hours, associated with nausea and vomiting since last 1 year, with vertigo episode increasing since last 3 months. And he also complained of tinnitus. The tinnitus character changes before the episode of vertigo. When elaborating the history, he denies having hearing loss, but complains of heaviness in ear during episodes of vertigo. So he has also history of migraine in past, but is symptom-free since last 10 years. So the patient has rotatory vertigo, which is lasting for 2 to 4 hours, nausea and vomiting, and the vertigo episode has increased in last 3 months. So what comes to your mind? Anybody? So it's you can diagnose it since the patient has hearing loss. So it can be either migraine or it can be menial disease or it can be a complex. So the diagnosis and the tests are simple. You have to do an audiometry test, and then you can do either a vestibular test, caloric test to rule out that if it is one-sided vestibular weakness or not, and role of MRI. So usually the role of MRI comes if you are not able to diagnose it, but the audiometry runs like this, right? So in the left side, and you can see that there is a short increment sensitivity index, which is on right side is 25 and left side is 90%. So this is a simple audiometry test, right? And you can get it done. But according to the literature, if there is unilateral hearing loss, asymmetric hearing loss, you need to do an MRI. So ideally you should write on the paper that CE MRI is needed to rule out any CT angle lesion. But this case will typically falls into the category of Meniere's disease, right? Then the patient low caffeine diet, some diuretics, betahistine and all that. And then if the patient does not respond, we give first dose of gentamicin, we usually use. And the other is low salt diet and low caffeine diet. This is very, very important. The dietary management in Meniere's disease is one of the important cause. Then 6 months later, the same patient come with, it was fine, vertigo resisting attacks of Meniere's. Detailed history told that vertigo is more severe, lasting for a few minutes, increasing on night and turning in back. So now that the vertigo character has changes, after 6 months the patient come has with a vertigo. So DD now would be that most commonly you will see that the patient is not responding to the treatment of Meniere's disease. He may have the recurrence of symptom of Meniere's disease. But mind you that in the history I have told that the patient 10 years back has suffered from migraine and he has no migraine now. So it comes that sometimes the patients of Meniere's disease will have migraine issues. Sometimes the migraine patients will have Meniere's disease, and there are subset of patients who have both. And each episode of 6 months or a year of no vertigo, they come back, you have to evaluate that what was the reason. Is it the patient has, and the patient will be able to, by the time if you counsel the patient, will be able to differentiate that what was happening preceding to the attack, right? Many times patient goes to some party and eat lot of snacks which are salt, heavy loaded in salt, and that does not count as a salt, and then after 2-3 of this episode, patients start having again the Meniere's disease symptom. So there is always a correlation between Meniere's and migraine, and many a time migraine patient not responding, they respond to the treatment of Meniere's disease. And even in migraine patient, I have seen that some will have transient hearing loss on one side during the attacks of migraine. So you have to take the history accordingly, that what are the symptoms, what are the associated autonomic symptoms, like autonomic symptom will more be in Meniere's disease as compared to migraine. These are some of the cases, like this is the case of palatal vasculopathy. On the left side you can see that the patient has one side Meniere's, totally hearing loss gone, other side is getting involved. Sometimes the one side is the worst side, the other side is nearly normal age-related hearing loss is there. So these are also cases which can present to you after 10 to 15 years later. Then coming to 30-year-old female complaint of vertigo lasting for few seconds to minutes. The symptoms are prominent when the patient lies down or get up in bed. She also felt dizzy when she tried to pick up something overhead kitchen cabinet. She has similar episode few years back, but it resolved on its own. So this typically tells us that it is a patient of BPBP, and you need to do Dix-Hallpike test, and you have to test all 6 canals. Many a times I have seen that when we told resident to do the Dix-Hallpike, they will just test only the posterior canal by the Dix-Hallpike and then say that oh, Dix-Hallpike is negative. But then you have to train your juniors, and you have to also practice that. Although the other canals are rare, interior canal, lateral canal, but it is not that rare if you are doing a vertigo practice. So you have to test for all 6 canals. I think this is beyond my this. In the clinical practice guidelines of BPBP, one should, the clinician, even I think every ENT surgeon should know how to do a Dix-Hallpike maneuver. or so that you know that it is a VPVP, the posterior canal VPVP is more than 80%, right? So left are anterior canal followed by lateral canal. So it is important that we should, and there is a strong recommendation against post-procedural restriction. So earlier I used to restrict patient that you have to sleep in this position, your head elevated and all that, but now that has already gone. I do not tell my patients. I do tell them that if you still feel some amount of vertigo, then if there is more than one particle, then they need to come back again, maybe 2 to 3 weeks later. And then reassess patient within 1 month after an initial episode, observation treatment to document resolution and persistence of symptoms. This is important, that you have to reassess patient even if the patient is fine, please call him and then you do all the tests and tell that he is cured of disease. So that when the next episode has happened, you know that it is VPVP recurrent happening, what is the cause, is it the vitamin D deficiency or hypocalcemia or other things. Then I think I will go to the cases otherwise. 20-year-old patient complained of vertigo since last 20 days with hearing loss and headache. He has also history of ear discharge in past, but no history of discharge at present. His anterocular test showed deviation to the left side. So clearly the left side vestibule is not functioning in a 20-year-old. What do you think here, history of ear discharge? Anyone? Anyone from the resident? No one is volunteering. I will not grill you. It's okay to be wrong. So what I am saying that in a vertigo patient, you should always look to the ears also, right? Okay. So it is a case of, I will not waste time, it is a case of cholesteatoma, which is irritating the lateral semicircular canal, right? So in this, the patient may have hearing loss, and they come with, when they have episode of vertigo, the discharge is ignored, the hearing loss is ignored, but when there is a lateral semicircular canal or any other canal fistula, then they come to us to access. And as we know that sometimes the cholesteatoma, attic cholesteatoma, the other cholesteatoma cannot have that profuse discharge, that patient complain of discharge, is forget that there is having discharge in childhood. So, and in fistula also various kind, the patient may have mixed loss, the patient may have profound loss, the patient may have only conductive hearing loss, depending upon the grades of fistula, like the lower and upper grades of fistula. So again, we will cover 1 or 2 cases and see if there is a clinical case. A 53-year-old female patient presented with dizziness, vertigo, imbalance since last 1 year, no history of hearing loss, no history of migraine and any other complaint. She has a history of right side headache and some numbness in ears. So you can see that the hearing loss was not there. And then this patient, we did an MRI and it came to be, so it was and here it was the clinically, the disc of paresthesia was there, right? There were other symptoms which tell us that post-pointing was there. So we thought that it's a cerebellar in origin, and then there was a cerebral compression on the middle cerebral triangle. So then the surgery was done. This is case of schwannoma. Then the patient has 35-year-old with sudden onset severe vertigo, vomiting and facial palsy. So this along with the hearing loss and the vertigo, the patient has facial paralysis, right? So you can think of a central cause in these kind of cases, because the patient has a facial palsy also. So you have to do an MRI definitely in these kind of cases to know that what's happening, and the audiometry then has a profound hearing loss, and this is what we found was that the patient has a small ganglioneuroma of right vestibule. You can see that the CSF was here into the internal acoustic meters, but here the CSF is not. These are rare cases, and only we could diagnose because the patient has persistent facial palsy which was not vibrating. But Avina Bell's palsy sometime, or the labyrinthine artery which is involved, it can present like this. Then I will go, this is the case. I just want to show one case. So the other is vitamin B12 and vitamin D deficiency. Like many vegetarian people have severe vitamin B12 deficiency. They come with dizziness, more of a dizziness and imbalance, right? So if the patient of one of your patient is not responding to the usual treatment, which you have diagnosed. It can happen with any vestibular syndromes, that a patient may have severe vitamin B12 deficiency. I have seen 100, 50, right? And once you give 4 to 6 weeks of give injectable, or you can give the nasal sprays now available. Do not give the oral, because orals are not adequate enough. The patient might have GI problems where it is not able to absorb the B12. So the injectable is good, and vitamin D deficiency, I have seen that if the patient has recurrent episode of BPPV, supplementing them with vitamin D when there is a very low vitamin D helps them to prevent recurrent attack of BPPV. That is my clinical experience. This I think I will just can we close this video? Okay, thank you. So this is a patient who complains of vertigo, and you can see that the patient is swaying, and once I put a small finger, she is stable, right? Then again after some time she is stable, and she complained to me that severe vertigo, disabling, she is not able to move, but when we just put a finger, she is stable, right? Just observe with the video. I have 2 videos to show, right? And everybody in the family understood that okay, she has some severe problems. The vitamin B12, the MRI is normal, everything is normal. So you can see the husband is putting an arm so that she does not fall down, right? And then you can see that she was nearly able to do the anterologous test without swaying, right? So these patients have episodes of vertigo due to VPPV or due to other, and then they go into the PPPV, right? So there is a typical symptom that the patient will, the examination will come as nearly normal, but the complaint will be very, very genuine. Like you will feel that okay, the patient is sick, is not able to move, and they will always use the walls. They say that they will be restricted to the bed. So what happened that after the vestibular insult, if there is no rehabilitation happening, and if the patient is distressed, then the rehabilitation is further derailed, and this patient can have problems. This is a 45-year-old male complains of vertigo lasting few seconds with episode like this for more than 100 every day. He is diagnosed with vestibular migraine and have partial relief of symptoms since last winter. Now he has tinnitus and mild hearing loss and referred by neurologist for evaluation of hearing loss. So there's something, episodes like 100. So this is typically a case of vestibular paroxysmia which happens due to the neurovascular insult, and there is a Chowda grading, and type 3, I have seen that type 3 is symptomatic many a times. But 1 and 2 you don't need to worry about. Many a times people comes with me with a scan that already reported. So this is what the Chowda 3 grading will look like. It will occupy more than 50% of internal acoustic meters, and there will be neurovascular conflict. If it is compressing the cochlear nerve, the patient will have hearing loss, right? And if it is not compressing, the patient will have severe episodes of vertigo. And you can yourself see in the MRI, sometimes it is not reported. So I have already seen that when I see an MRI for my vertigo patient, I want to see my CSF in the internal acoustic meters. In a T2 cut or C sequences. C sequences is better. If there is a fluid in that, then that's rule out vestibular neuroma, that's rule out various things. And then I want to see, you can see here that how is this one, okay? So in this area, the lymphatic sac will come. So if you see that sometimes the sac is very, very enlarged, like in Meniere's disease, you will find the sac is quite enlarged. Okay, during the acute attacks, and you can do for that gadolinium enhanced MRI. You have to inject gadolinium 24 hours before that. But usually that is not required, that's an invasive test. And usually from the SISI test, and from the symptoms, and from the audiometry, and from the MRI, we are able to diagnose these cases. So considering that when you are ordering an MRI, you should not rely completely on the report of a radiologist, which has so many scans to report. So you will just see that okay, there is nothing, but these things, finer things you need to see in your patient if you correlate. Yes, can we play this video?
जब मैं चलती हूँ तो मेरे को ऐसा लगता है कि मेरे पैर जो मतलब मैं बोट में मेरे पैर ऐसे बोट में जैसे होते हैं वो होते हैं।
Can you start again?
वॉल के सारे जब मैं चलती हूँ तो मेरे को ऐसा लगता है कि मेरे पैर जो मतलब मैं बोट में खड़ी हूँ मेरे पैर ऐसे बोट में जैसे होते हैं वो होते हैं ऊपर नीचे होते हैं। वॉल के सारे किनारे मैं चल लेती हूँ 4,000 स्टेप्स भी चल लेती हूँ। लेकिन बीच में चलने में तो तब भी किनारे चलने में भी ऐसी फीलिंग होती है, लेकिन एक डर नहीं होता कि मैं गिर जाऊँ। लेकिन जब सीढ़ियाँ में हाँ बिना पकड़े उठे चढ़ जाती हूँ और खड़े होकर भी काफ़ी देर सब कुछ काम कर लेती हूँ। लेकिन वो उसमें मतलब यहाँ पे एक तो राइट ईयर का जो मेरा वेस्टिबुलर मतलब राइट ईयर में मुझे प्रेशर सा होता है, यहाँ पे हल्का सा माइनस जैसे पेन सा वो फील होता है चलते समय, और लेटने में बैठने में कोई प्रॉब्लम नहीं।
So what is this syndrome? Anyone? So she complained that she is feeling she is on a boat, right? So the syndrome called is mal-development syndrome. Actually, it's a neurological condition, persistent session of rocking, swaying, bobbing. So actually, it was typical earlier when the ships were running for 20 days, 15 days, somebody coming from ship voyage, they will feel that okay, they are still on the ship. So like some of you might have traveled a train journey, which is a longer duration. It is not 2 hours, 4 hours, that's okay. But if you have traveled for 24 hours, 36 hours, when you sleep, you still feel that you are moving in a train. And once you sleep, then next morning you feel better, okay, right, now I am fine, better. So these kind of symptoms happen. It is mal-development syndrome, but these all now come into the bigger umbrella of triple PD, right? So triple PD, you need to hear also like patient will have symptoms, and these patients more common in women, especially in perimenopausal. This also have some history of migraine sometimes. So you can say the patient told that there is some pain here and all that, right? So this patient has previous history of migraine, but she came all the way from MP because she was disabled. And she was not moving out of bed, but after the last counseling and some benzodiazepine, second time she came with this complaint, like after 3 months. But now she is able to walk, at least she is going out in the house, and the outdoors she does not require any help. But in the always feel that she is dizzy, so that's why she is avoiding any social gathering and all that. So these patients require medication like benzodiazepines, and sometimes the VRT is the most important. Most of us treat vertigo but do not tell about VRT. And VRT is to be not given. I have seen that if I explain just 3 or 4 exercises, what I do my clinical practice is that they have to fix the thumb, move their head, and then they have to do this. So this is for the VOR, right? And then they have to do, if the patient is unilateral vestibular failure, then I tell them that you can hang a ball from the height and then you can use a racket to use it. Now it's evaluate the situation where I think man can put that on a better picture. But if you will talk to the patient and tell them that okay, this is the things which if you will in the past in the busy practice when I used to tear up page and give it to the patient did not understand how of it, and he will not do the exercises where he will dizzy. You have to tell them that you have to do that exercises which you will more dizzy, and slowly then rehabilitation. And rehabilitation happen in the cortex of the brain. It does not happen in the vestibular system. Some improvement will happen, but it is the integration of the VOR and the proper substance and other that cause the vestibule to cover up for the one side vestibule. So with this, I finish. I try to cover that what syndromes are there common and how can they mimic each other. I think if there is any questions, I will be happy to answer.
Panel of chairpersons. The first chairperson is Dr. S.S. Kapoor sir, Senior ENT Surgeon practicing at Prayagraj.
Our next chairperson is Dr. Mahesh Javedi sir, who is the Senior Consultant in Varanasi. in science, which has made relevance with the mid-90s
foundation set by Dr. Arijit, Dr. Ananya, and the different cases which Dr. Amit just talked about. I'd like to talk about Meniere's disease. So, how it can change presentations over time. So, the Barani criteria for Meniere's is that for a definite Meniere's disease, we need to have at least 2 attacks of vertigo which last for 20 minutes to 12 hours. And it should have a fluctuating hearing loss in 1 year, starting with the low to the middle frequency. But what is that? What patient is finding most disturbing? That is the vertigo, right? And here we are seeing that this does not address how the vertigo is affecting the severity of the disease, is not addressed in this kind of a classification. So here I'd like to talk about how vestibular tests actually help in our diagnosis of Meniere's disease. The fact is that the vestibular findings can be found very early in the evolution of Meniere's, while the characteristic audiological findings take longer to evolve. And because these audiological findings are fluctuating, often they are missed in the early stages. The vestibular tests also give us an insight into the pathophysiology of Meniere's. And according to the results of our vestibular evaluation, vestibular test over time, a clinical spectrum of Meniere's disease may be proposed. So this is my this is the editorial which I wrote for neurology clinical practices, talking about the dynamic physiology in Meniere's disease and how the treatment can differ at different stages according to the stage of the problem. So let us understand a little more about pathophysiology of the Meniere's disease. It is a dynamic phenomenon, and the order of involvement is that it first affects the pars inferior, the cochlea and the saccule, and then goes to the pars superior. What we consider to be due to endolymphatic hydrops are the compression symptoms, fullness in the ear, tinnitus, and reduced hearing. And the apical turns of the cochlea are the first to be involved, and that is why the low frequencies are affected first. When we do serial audiograms of these kind of patients, you will see just a low frequency loss right at the beginning, but as the disease progresses, it expands to more towards the middle and slowly may even go towards a flat hearing loss. The membrane rupture theory caused by the compression leading to potassium toxicity is one of the foundations of Meniere's. And what happens is that in the initial stages, there is because of the increased potassium ion levels, the first order neurons are affected and result in an initial excitatory nystagmus. I'll just play this again. So you'll see an ipsilateral irritative nystagmus which is very weak. And you'll be able to catch this if you see these patients very early or when they are just going to have an attack. Then follows the rupture of the membrane, release of the potassium-rich endolymph into the sodium-rich perilymph. And as the potassium concentration increases, there is a blockage of the action potentials, resulting in peritic nystagmus, which is beaten contralaterally. Okay? So this is what we typically see in our Meniere's disease, in which you are seeing the nystagmus, which the fast component is towards the healthy ear. This was a very good paper by the Korean group led by Ji-Soo Kim, in which they talk about the evolution of the vestibular findings during and between the attacks of Meniere's disease. And I'd just like to also talk about otolith function, what they've talked about, the subjective visual vertical. This is a test for utricular function, and during the attacks, the patients often have affected SVV, subjective visual vertical, of how they are able to perceive verticality. The CVEMs can be affected as well, resulting in abnormality. And then when we come to semicircular canal function. So Dr. Ananya had talked about how different functions can be affected in the test in Meniere's, and I'd like to just go through the basic physiology behind this. So the vestibular cells are of two types. The type 1 are in charge of high frequency, and it is measured by the VHIT, while the type 2 cells are in charge of low frequency movement detection, and they are measured by the calorics. The function of the low frequency is because the low frequency testing, the caloric test is actually a low frequency test, while the VHIT is a high frequency test. And that is why this dissociation between the calorics can be an indicator of frequency dependent impairment. And the hair cells, the type 1 hair cells or the vestibular cells are still functioning even in advanced stages of Meniere's disease, while the calorics are affected at a much earlier stage. And these complementary tests actually give us an indication of the function. So we all understand the importance of frequency testing in our audiological tests, but equally important is the frequency testing in the vestibular test. And here you can see that this caloric VHIT dissociation can be a biomarker of Meniere's disease. Now let us go to Tumarkin's crisis, or the autolytic drop attacks, in which there is an abrupt loss of muscular tone in the lower frequencies, which is related to a sudden otolith dysfunction. These patients just fall, they lose their muscle tone, but there is no loss of consciousness. And this is very, very important, no loss of consciousness. And the mechanism is a direct mechanical deformation in the otolith organs. Treatment for these patients is IT gentamicin. So now, according to these things, we need to identify how are we going to treat our patients of Meniere's. So if the patient comes in the acute stage, yes, a short dose of vestibular suppressants would be required. But this is usually, an acute attack lasts usually less than 24 hours. So the suppressants which you really need to do is just for that 1 or 2 doses. But the long-term treatment involves the dietary restrictions, the salt, the caffeine, along with certain other things like the diuretics, there are different ones which are used, Diamox, you can say acetazolamide or spironolactone, histamine agonists like beta-histine in higher doses, and steroids have often been used, pointing to the autoimmune mechanism of Meniere's as well. So using intratympanic or oral steroids. I will be talking a little bit about migraine prophylaxis as well, because just as Dr. Amit just talked about the complex or the overlap of Meniere's and migraine, and in fact in all of my Meniere's patients I do give a migraine prophylaxis because there are often similar or overlapping symptoms which need to be treated. Just moving on a little bit to the vestibular migraine part, which is the most common cause of episodic vertigo. And the vestibular symptoms have been already talked about, but the important thing to understand is these are very varied. There are all different times, at rest, at movement, in moving places, or even during head movement. And when we talk about the clinical characters, you can see that when vertigo is present in all the patients, the headache is present in only 60% of patients. And what this means is that headache is not necessary for a vestibular migraine diagnosis. And you often say that when you see it clinically as well, that when you talk to your patients that this is what you have a vestibular migraine, and the first thing they will say is, no, I don't have headaches, it cannot be migraine. So what you need to talk about is how migraine actually is a nerve problem, how it can affect the different areas. Dr. Ananya brilliantly showed that whole table, that the algorithm of how the different areas, so you can have your ocular symptoms, the vestibular symptoms, the cervical symptoms, the gastric symptoms, all of them, which all can contribute to your diagnosis of vestibular migraine. Now, Meniere's migraine is now considered to be the two phases of a common condition, and that is why they have an intimate relationship in both their presentation and their treatment. So, just working a little more on the vestibular migraine treatment. So, when there is an acute attack, when I talk about vestibular migraine, I will talk about aborting both the headache, if the patient has it, and aborting the vertigo. But if the patient has recurrent episodes, more than 3 episodes in a month for 3 months, or episodes which are incapacitating, affecting their lifestyle, we need to also go for prophylaxis. Lifestyle remains a very, very important part of treatment, and I tell my patients that without working on lifestyle, no matter what treatment I give, it will not work. Just skip this, and we've already talked about this. Now, how do we choose our migraine prophylaxis? This is actually a very tricky problem, because there are different categories of drugs which can be given for patients. And how do I choose which patient will get an SSRI, which will get a beta blocker, or which will get a sodium channel blocker? The important thing to remember is always start with monotherapy. We go for combination only if there is inadequate control after 6 weeks. And when we go for combination, always add a drug which is from a different category. Never combine drugs from the same category, because it will potentiate the effect and increase the side effects. Now, how deciding? You'll see that different patients will be getting different treatment, and the decision lies on these various factors. The patient related, the age. A younger patient, maybe children in which we see vestibular migraine patients, we will probably prefer something like a propranolol or a flunarizine. Male, female also have different treatment planning. So a young, maybe a 25-year-old patient, male patient, having vestibular migraine, probably my first choice would be divalproex. But 25-year-old female, probably if BP is normal, I will go for propranolol. So you need to consider all of these things, and the most important thing is what is the side effect of that prophylactic drug. Why this is important is you'll see that when I talk about the drugs, side effect, why, like for that same patient, 25-year-old male and female, why these two drugs are different? It is because of the side effects of both of these drugs. I cannot give these divalproex or the potassium channel blockers, or sorry, the sodium channel blockers to a patient in the reproductive group. That is usually not the first choice. But if I give propranolol to a young adult, it can cause things like erectile dysfunction, etc. When we talk about the antidepressants, the tricyclic antidepressants, the SSRIs and the SNRIs, which are very, very effective in our migraine prophylaxis, and it is because they increase the availability of serotonin, resulting in mood elevation. So, when will you prefer this drug? When patients have depression, neck pains, disturbed sleep, but never give it in children or patients with glaucoma or heart disease. The beta blockers, propranolol or metoprolol, I give a lot of propranolol to my patients, and it's said to turn off the locus coeruleus, the area which is actually the generator of the migraine episodes, and it blocks the arterial dilatation. So we give it in patients who have a lot of anxiety, who have coexistent hypertension, and in children, but never give in asthma or in heart disease. Flunarizine, the calcium channel blocker, which increases the neurotransmitter release and decreases the neurotransmitter release, and we give this in children and patients who have severe vertigo, because flunarizine also serves as a abortive therapy for vertigo. But never give long term, and never give it for people over 60, because it can cause secondary Parkinsonism. When we talk about the membrane stabilizers like topiramate and divalproex, they work by stimulating the GABA receptors, and they block the cortical spreading wave of depression. So one of the side effects of topiramate is weight loss. So it is one of the preferred drugs of patients who are overweight, who have prolonged migraine, and also in patients who have been long therapies, especially very long duration painkillers or other migraine prophylaxis. In those patients, topiramate works very well. So again, Dival is very, very effective in the age group of males 20 to 45. Magnesium is one of the common what we add to almost all our migraine prescriptions is magnesium, and it is said to be very, very effective in doses of 400 to 500 milligrams per day. Now, the question is, it's often reported that many, even if you do not treat them, they'll be better, say, down the line. Down the line means how many years down the line? It can be like 15 years, 20 years. It actually dies out with age. But the effect of it is because the endolymphatic space increases with aging, and so they don't have so much of effect with the rising pressure of the endolymph. When we talk about the glycerol test, give the patient glycerol and then do serial audiograms, it is said that it has a low sensitivity and it is not very effective in early migraine patients, early Meniere's disease. ECOG, yes, can be done. So the treatment options again. So I'd just like to conclude that the number of involved vestibular organs which we have, so by examining each part of the vestibular system and the auditory system gives us a much better indicator of what all is affected and then how the treatment should be done. Thank you so much.
Meniere's हमारे समय में I am an old person. हमारे समय में Meniere's को as a डस्टबिन लिया जाता है. कोई भी वर्टाइगो है Meniere's होता है. Improvements, advancement है कहाँ? हमारे समय में बहुत अधिक नहीं. Thank you, ma'am. And one request I will ask for Dr. Amit Kesri and Dr. Ananya. Please think about MCH ENT. It's now needed. We have grown up and we can go for that. Thank you very much.
Thank you, ma'am. Is a member of multiple associations.
So today my topic of presentation, approach to a case of central vertigo of brief understanding, VNG based case study. So I just going in the brief like discussed prior also, vertigo and dizziness according to grand symptom, that is very well explained by Dr. Ajit. And sensation of motion when there is no self motion, vertigo, Dizziness, sensation of disturbed, impaired spatial orientation. Vestibulo-visual symptom, external vertigo, movement into blur, oscillopsia, visual tilt, and visual lag. Like oscillopsia, what is it? The people are thinking that I am moving in vertical upward, like caudal rostral plane. This is the bobbing sensation we are getting due to involvement of the some otolic pathways, utricles, sacules. That can be symptom we can correlate with where is the origin, why it is actually involved. So we can rule out with the basis of symptom where is the pathology. Like visual tilt, it's a symptom arise from the utricle and sacular part. Utricle is maintaining the balance at the horizontal level and sacule at the vertical level. Utricle, but while we are in the translating in the plane. I just discussed those points that is not discussed prior actually. So with the history, how we can connect with the clinical history with the anatomy of the involvement. So in visual lag, something is lagging behind, spatial orientation is defected. Visual tilt, something is like utricle and sacule level that is defected. Like while we are in utricle, we are translating in the some plane. We are moving in that trade. So the utricle, the otolic is stimulated at the horizontal plane, so that we are getting a sensation of imbalance, dizziness, even the spinning sensation also. While where is the head tilting? There is otolic particle, that is medial part of the utricle, that is stimulated. So we are just head tilted and we are getting the sensation of something is tilted behind. Medial part, lateral part, that is different part of the utricle, that is also affected, and we will getting the symptom accordingly. But what happened? Like we are feeling the weightlessness, gravity, there is no gravity. Then what happened? Because of the gravity vector of the sacule, otolic particle in the sacule, that is giving the sensation, because vectors have become negligible. So we are feeling that there is no gravity. We are on the light plane. Apart from postural symptom, unsteadiness, directional pulsion, we are falling on the one side. If the one side is the vestibule is not active, we are thinking that we are fall on the one side. Balance rated near fall. मैं गिरा नहीं, बस मैं गिरने वाला था. There is imbalance present. Balance rated complete fall. We have to assess all these one by one, and we have to think where the symptom arises. Now we have to think central and peripheral part of the vertigo. These are the long history, history taking drug diseases, so that we can rule out where is the symptom. DPPV, vestibular neuritis, Meniere's disease, lymphatic fistula, Cogan syndrome, otitis media even can cause the peripheral vertigo, acoustic neuroma, vestibular paroxysmia, vestibular migraine in the central causes cerebral infarct, CV junction abnormalities, child formations, multiple sclerosis, epileptic vertigo also. So these are the symptoms we have to think while we are taking the history. Other systemic causes like drug toxicity, polypharmacy is very much common in our scenario. That we have to rule out which drug this patient is taking in our history. CV, hypotension, syncope. We will get the symptom like in syncope, blackout. There is a loss of consciousness also. But in other, when there is a fall present, cataplexy, there is a consciousness is maintained. In cataplexy, there is a loss of muscle tone. In tubercle crisis, as ma'am explained prior, there is a fall present, but consciousness is maintained. So we can think, we can differentiate on the basis of symptoms. Endocrine disorder, hypoglycemia can cause hypothyroidism, Addison disease, collagen vascular diseases, hematological causes that can also cause. Psychiatric disorder that is very common in our society, hyperventilation, panic attacks. Simple aging process can also lead to the imbalance, dizziness. So now just we are landing in the maintenance of the balance, how we can maintain the balance with the eyes, inner ear, proprioception, that coordinate with the brain, and we will maintain the balance. But what happens when there is disparity, when there is a pathology, vertigo, dizziness, vestibulo-visual symptoms, postural symptoms comes in picture. So there is a long list of the physical examination we have to do at our regular routine practice: pulse, BP, orthostatic hypotension assessment, vasovagal syncope, Eye examination, that is very much important. We can assess on the basis of eye, like pupillary hippus, that is commonly we can see in vestibular migraine patients. Apart from there is a convergent spasm that can also be seen in the vestibular migraine patients. Diplopia, that can be also seen in different like myasthenia gravis. In tilt, when the tilt versus translation reaction that is present, and there is a tilting of the eyeball that can also present as a diplopia, so that we can assess at the various level where it is. Because vertigo as a diagnosis we can only rule out on the basis of just ruling out one by one diseases where it is. So vibration test just to assess the proprioception, like visual deficiency, there is a vibration test is reduced. So we can rule out one by one. Apart from, we are doing sensitivity sliding denial test, in which we are just following the patient is standing on the foam. Apart from understanding of the firm surface, we can rule out one by one what is it. Escalating motor complexity, tandem walk is singly like a standing retropulsive test, Romberg test, 2-2 test we can do with the brain stem mapping, with the fine touch temperature on the face, body, right and left side of the extremities. So I just don't go in the detail. This is the briefing, what we are doing, and we can rule out. Unterberger test as we explained prior also. So in examination, head impulse test we are doing, normal impaired, skew deviation, what is vertical, skewed or not, and nystagmus. Head impulse test, that is very much important test we can do, we can assess the VOR. And full hint test, we can detect the central lesion with the sensitivity of 90%, which is higher than the MRI also. We are performing here head impulse test. The bilateral catch-up scats as you can see here. Bilateral catch-up scats you can see here. What is this? This is the assessment of the three-dimensional of semicircular canals. You can see in the three-dimensional plane, and we will get the different type of the pattern. So we can assess one by one in different plane, RARP plane, LARP plane, different plane, the functioning of the semicircular canals. So these are the point we have to follow in clinics. Now the protocol for the vertigo. Most important one, the history one, after that the examination. Then we can rule out everything and we can make the diagnosis. What is it? Now with the case history, 49 years male, sudden onset of severe spinning sensations in 3 days, inability to focus well, with the feeling of surrounding object moving around, tendency to fall on the right side, so need support for ambulation, comfortable on wrist, past history of similar vertigo episode, no history of hearing loss, oral fullness, tinnitus, so that we can rule out here for many years, no history of fever, respiratory tract infection, diabetes, so that we can rule out like there is no fever, no viral infection, so we can rule out like vestibular neuritis, patient is on antihypertensive medication. So this is also the clues. Apart from that, MRI is negative, only the mild compression at the C level is present. So we can say MRI is negative. What is it? So I have done the hint test in which head impulse test, that is normal. Skew deviation, there is no deviation. Nystagmus, spontaneous left beating nystagmus seen. And with the long sensory denial test, motor complexity, retropulsive test, Romberg test, patient is swinging towards the right side. Now I landed on the video nystagmography, decoding of eye movement by which we can reach the brain. Where is the lesion? So this is the second. You can see this is saccadic nystagmic intrusions are seen here. This is the saccadic intrusions. You can see here.
You press.
This is due to the eye central anomaly. This is the spontaneous left beating nystagmus that can present as a change. Similarly, in the broken pursuits we are performing, you can see there is a pursuits are broken at different level due to the left beating spontaneous nystagmus. See that not clearly that is visualized, but there is a nystagmus present. Apart from in that spontaneous dart, on removal of the fixation, you can see there is a left beat nystagmus clearly visible now because the removal of the fixation. In the gaze test, you can see in the leftward gaze there is a left beating nystagmus that is more intense in horizontal direction. So we can compare the slow phase velocity of the different gauges also. You can see on the right word, left beat nystagmus seen. On the left side, it is not visualized here due to some issues. But on the left side, it's up beating. So there is a path changing. The left side, it's a horizontal, and the right side, it's a vertical. So there is a path changing nystagmus that is clearly seen in the central cases. So differential diagnosis, early stroke, transischemic attack, partial pica infarct, partial or complete ICA infarct, superior vestibular neuritis, first attack of DPPV, acute Meniere's attack, acute attack of vestibular migraine, labyrinthine infarct. So we can rule out one by one. Posterior pica cerebral artery involvement. How we can rule out? His hearing is intact here. MRI is negative. So we can say there is a mild micron size of the MRI, like a stroke or transient ischemic attack that is found, but hearing is intact. Symptoms are prominent, so we can pica is most common probable diagnosis. ICA, why it is not? Because ICA supplies the hearing part of the lip cochlea. Hearing should be involved in case of the ICA involvement. Anti-inferior cerebral artery involvement. Superior vestibular neuritis. Head impulses in this case is positive. Is normal. So we can say head impulse is normal. So peripheral part is normal in our case. So we can rule out vestibular neuritis here. That is not 100% in any vestibular cases. We can rule out the one by one. Then we can make the diagnosis. First attack of BPPV. There is no positional input. It's a spontaneous one. So it is also on the rear side. Acute Meniere's attack, tinnitus, hearing loss, everything is clearly clear in this patient, so we can rule out this is not the Meniere's attack. Vestibular migraine, there is no history of headache and previous history of that episodes. Labyrinthine hearing is intact, so we can rule out the labyrinthine infarct. So my diagnosis is MRI negative, posterior circulation stroke, probable partial pica infarct. So this is the thing. For any queries, you can connect me for this. I think so. Next one is also mine. So next is the approach to a case of BPPV. How to match a nystagmus to the correct maneuver in BPPV upper zip. In easy words, we are just getting the patient posterior canal, lateral canal, we are getting, and we can easily treat very well to them. But what happened when there is a complex phenomenon is in front of you? Now the era, everything is complex, not a simple one, so we have to think for the complexity also. So what is it? Just go through it, then tell me what is the diagnosis here. I am performing dysalpic right test. On changing the position, we are getting few right speed, then upbeating nystagmus, few right beats also, upbeat nystagmus, and few downbeat nystagmus also. Upbeat torsional nystagmus. So what is it? Here the particle is moving in the canal, here, index salpic position. Particle is moving in canal, then we are getting upbeat torsional nystagmus. While the rebounding, rolling back, we are getting reversal of that nystagmus. So in between we are getting that part also. Why the few right beat? It is a canal conversion or multi-canal? What is it? There is multi-canal because initially we are getting the few right beats. If there is canal conversion, then upbeat nystagmus will come first, then after the lateral horizontal nystagmus will come. But here the horizontal one is also in the head position. So there is a multi-canal VPPV, and so the particle is moving in the canal, and why we are getting the horizontal, because horizontal canal stimulation. Some particle water is in the horizontal canal that is moving back, and that's why we are getting the horizontal right beat nystagmus here. So we can clarify where is the canal and what is the nystagmus we are getting here. So now the question arises how these nystagmus we will get, what is in like posterior canal. Posterior canal, there is which much is stimulated in posterior canal?
Multi-VPP, how do you treat? You treat the one having maximum nystagmus, or you treat both of them together?
So one by one, we have to treat one by one. Better to treat one by one, otherwise you will be more confused what is going on, or we can take a like 10-20 minutes gap between the treating these members. So in posterior canal, we are getting vertical nystagmus. So for vertical nystagmus, this is the posterior canal. That is stimulated. We are getting the first muscle which is stimulated on the ipsilateral side is superior oblique. Superior oblique action is torsional one. Torsional action. Ipsilateral side, posterior canal, if the right posterior canal, right superior oblique is active, and there is a torsional action in your picture. Apart from the torsional action is the depression action also, because जब हम इसको घुमाते हैं तो ये थोड़ा सा नीचे भी दबता है. So there is inferior one movement also and torsional one movement also, and that's why we are beating towards the right side, because slow phase in the leftward and beating towards the right side. We are getting some downbeat, so beating some upside. So for right posterior canal, we are getting upbeat right torsional nystagmus. Apart दूसरे side में contralateral side inferior rectus, that is only having the first primary action is only the downward vertical movement. So that is the inhibitory side. With the lateral canal, medial rectus. Why it is not in a torsional in the lateral canal? Because it is stimulate the medial and lateral canal. Medial rectus and the lateral axis. So there is only the horizontal movement. There is no torsional movement. Right lateral canal stimulate the medial rectus, and opposite side the lateral rectus. So it is in this direction and beating toward the same side. So push is opposite side and beating toward the same side in the horizontal canal. In anterior canal, what is it? Why it is not prominent? It is written in the book. There is a torsional component is the least in the anterior canal. Why it is happened? क्यों होता है ऐसा? Anterior canal give the ipsilateral stimulation to the superior rectus. So superior rectus is the primary action is only the vertical one. There is no torsional. The secondary action is the primary action is the vertical one. So we are stimulated and we are getting the downbeat nystagmus, because superior rectus is stimulated and we are getting the downbeat nystagmus. Apart from opposite side, we are getting the which muscle is stimulated, inferior oblique in anterior canal. So that is in inhibitory side, and we are getting mild torsional in anterior canal. Most prominent is a vertical one. So we are getting the downbeat nystagmus in the anterior canal. Right side, superior oblique is right posterior canal. Superior oblique is more active. So we are getting the torsional one. So we can clarify which type of the nystagmus we are getting. Accordingly, which canal is involved, and we can treat well with the maneuvers if we diagnose the proper canal. So these are the like primary actions, medial rectus. I think so it's a fast one, or we are able to absorb the things. Medial rectus adduction, lateral rectus abduction. The horizontal works. Superior rectus elevation, and inferior rectus primary action is depression. Superior oblique in torsion. The primary action is in torsion, so that we will get the more torsional part in the posterior canal stimulation. Inferior oblique X torsion. So this is also torsion. Torsional, give the torsional movement as a primary action. On the basis of canal stimulation, nerve stimulation and muscle stimulation, we will get the nystagmus pattern. These are the superior oblique action. Muscle superior oblique attached on the wall of the top notch of the eyeball. How we can assess? Sometimes it's more vertical. We cannot able to judge which side is involved. कौन सी side involved है? Right है कि left है? हमें right ही play करना है कि left ही play करना है? Then what happens? Then हमें क्या करना होगा? Let me think कि patient को हमने लिटाया, पीछे लिटाया, फिर हमने उसको बोला कि आप गेज पे देखो, rightward गेज पे देखो. Rightward गेज पे अगर हम इधर देख रहे हैं तो torsional ज़्यादा वर्क करेगा कि depression वाला? यहाँ से खींचेंगे तो टॉर्जनल एक्शन ज्यादा दिखेगा या नीचे टॉर्जनल वाला, क्योंकि पुली एक्शन इज मोर, वेक्टर इज मोर ऑन द टॉर्जनल साइड. सो वी विल गेट द टॉर्जनल मोड. वी कैन डिसाइड ऑन द टॉर्जनल साइड, टॉर्जनल right टॉर्जनल, left टॉर्जनल. We can decide which side is involved. So we can, that is like in regular practice we are stuck at some point. We can rule out which side is involved and we will treat better. So in like this, we can say the patient, see on the leftward gaze, on the temporal side we will get more torsional vector and we will get more torsional which side is involved in the posterior canal. Any queries apart from this? This is the horizontal part. So let me start with the macular technique. See the nystagmus of the pattern and where is the particle. With the eye movement, we can reach at the footprint of the otolith particle. This is which type of the nystagmus? Horizontal, right beat nystagmus we can see. In the supine position, particle is here, but in the rightward direction, particle move from here. So it's beating towards the right side. So initially there is a right beat nystagmus, because particle is moving this one and we are getting the right beat nystagmus. Apart from there is a torsion and twist present in the lateral canal. That is more twisted canal in the labyrinthine system. There is a angulation of the 30 degrees, so the particle move faster. So we will get the intense nystagmus during the turning. Apart from the supine position, again the particle is moving back from here to here and we will get nystagmus. Apart from while we are in the, like हमने टर्न करा के पेशेंट को लिटाएंगे तब हमारा पोजीशन चेंज हो जाएगी and we will get again the reversal of the nystagmus. Again, this is the lateral canal stimulation. Medial and rectal and rectus muscles mostly involved in this case, and we will assess the nystagmus. Which position is it? Pitch forward and pitch backward test. We are getting horizontal nystagmus. Initially there is a pitch forward. Pitch forward position, head is in forward position. Labyrinth should be in this direction. The particle is moving from here to here. Pitch forward. So moving, it's the right side. Which side is involved in the horizontal canal? In the pitch forward can decide in geotropic pattern of the lateral canal which side is involved for the horizontal canal. Apart from in the pitch backward, that is upbeat nystagmus. Particle is moving from here to here. So we can assess posterior canal is also involved in the pitch backward. That is most stimulated canal in pitch backward is posterior canal. So we will get the upbeat nystagmus. Is it again the multi-canal? We can assess the site also, which site is involved. So the pitch forward, right beat nystagmus, right lateral canal. Pitch backward, upbeat right torsional nystagmus, right posterior canal, BPPV. So it's a multi-canal BPPV present here. This is all twist and turn present in the labyrinthine. This is a human inner ear corrosion cast I have taken from the Verani Society, Sweden. picture, you can see there is a twist presented in the different anterior, posterior canal and lateral canal, and there is a more angulation in the lateral canal. That can cause the canal jam more frequently in case of the lateral canal. This is the research work how the particle move and give the different slow phase velocity pattern. So the take home message: by observing the eye movements, we can decode the journey of the particle in the canal, their location, mass, size, gravity drift driven, and direction of the fall driving themselves through these subtle ocular signals. And these are the same elegant eye movements. As our guide, we can steer the particle back to where they belong, restoring the balance with precision. Thank you.
Come forward and compensate Dr. Pratishtha ma'am with a small souvenir.
Field advertising, it's really appreciable. But I have a suggestion for all of us that we should come pre-study her topic to understand in a better way.
It's a little bit complicated.
Yeah. So to understand in an easy way, I would like to request you as a prepare it in a more different way. Anyway, thanks.
Various kinds of problems of the inner ear even to the brain and DPPV. But now let us talk about vestibular compensation and how rehabilitation forms a very, very important part of our treatment and management for our dizzy patients. So I'd like to start with some basic physiology here. So we have both labyrinths which are giving a tone to the vestibular nucleus. So suppose this is 10 and this is 10. At the vestibular nucleus, it is sensing an equal input, or you can see a sense of equilibrium, right? Now when I turn my head to the right side, what happens? The right side it is stimulated, so it will give a higher tone. So suppose this was 10 and this becomes, say, 15. But the other side is inhibited. So from 10, this probably goes down to maybe 7. So what is my vestibular nucleus now sensing? 15 and 7. And what that means is that the nucleus senses that there is a sensory mismatch, and it knows that this is because the head has turned to the right side. If I were to turn to the left side, the similar thing. Left side, increased tone, right side, decreased tone, brain sensory mismatch, and which is the higher tone is to the left, and what my brain will recognize is that I am turning to the left. And when there is an insult, this keeps on happening, so the patient constantly feels this dizzy feeling. So turning to the right, there is increased tone to the right, and when there is an insult, there will be only the tone on the right side is reduced, and what this results is in the spontaneous nystagmus. Because of the mismatch of the semicircular canal function, it results in spontaneous nystagmus, which leads towards the healthy side. Now, if this were to happen, the brain has to come into play, and the cerebellum actually gets activated, and it starts what we call the cerebellar clamp. What that means is that the cerebellum, because of this massive asymmetry, patient is feeling that she's spinning, but then what it does is actually works on the healthy side. So if this was 2, this was 10, the cerebellum comes and goes to the 10 and reduces it, right? So now suppose it has become 2 and maybe 5 or 6. Now there is less of a mismatch and the patient stops feeling dizzy, the spinning, but they still feel unsteady, right? So that is what a rapid resolution, and this is called cerebellar clamping, what the central nervous system comes into play and reduces the mismatch. Because of this, static compensation occurs. So at rest, if the patient is just not moving, just at rest, there will be no spontaneous nystagmus now, and the patient will feel better at rest. However, on movement, there will still be oscillopsia and postural instability. Now, for vestibular compensation to occur, there are various strategies which can be brought into play. First is restoration. Restoration means if there was some damage, some natural restoration from the body, but in humans this is actually very, very low. And with habituation, trying to repeat the same movement, habituation, these two mechanisms, the restoration and the habituation, work towards a static compensation. That means the patient will feel better at rest. But for dynamic compensation to occur, for the patient to be stable even during movement, adaptation needs to be brought into play. And for this we need sensory inputs. We have to activate the central nervous system, the visual, the proprioceptive, all of these things to be able to actually activate adaptation. That is the neuroplasticity. And how it really works. Because my right vestibular nerve has been affected, all this adaptation actually works through my other side, my healthy side, activating this area, and then this is transmitted through the vestibular commissure to activate the right vestibular nucleus. So even though you will not get a complete recovery of the vestibular function, because of adaptation we can get a recovery of the overall function. So the vestibular commissure activates the opposite, the affected side, to be able to activate it and result in recalibration of the vestibular activity. Now the vestibular ocular reflex, as Dr. Arijit talked about in the morning, is one of the fastest reflexes of the body. It is just 7 milliseconds. And if you compare this to our visual reflex, which is at 190 milliseconds, or our auditory reflex, which is at 160 milliseconds, you can just imagine how fast this is. And when it does get affected, what happens? It is much beyond the spinning. The patient cannot focus during movements, cannot multitask, has a fear of falls, and in fact often they get isolated. They don't want to go out because it makes them feel unsteady and there may be even a risk of fall. So when we see any patient of vertigo or dizziness, the first thing we always do is history. That will always remain the foundation. But then we need to go on to diagnostic tests to be able to develop or get a differential to understand what are we dealing with, what is the site affected, what is the disorder which is causing it, and from there we decide what is our treatment option, whether medical, maneuvers as Dr. Pratishtha had talked about, is it vestibular rehab or counseling. So we have a workshop in the afternoon on the various diagnostic tests and the importance of these tests. We'll be talking about it. But once we have been able to identify the site of lesion, we also know how to tailor our rehabilitation to that problem. We don't want to give any you can say, a generalized form of rehab. We have to customize our rehab programs according to the requirements of the patients. And in fact, in our own series, we have seen more than 45% of all patients do require vestibular rehab. So we are all from the ENT background and we understand audiograms very well. So just giving that as an example, just looking at these audiograms and you'll immediately form a picture, what is the probable cause and how will I treat this patient, right? So if it was this, you can just immediately, okay, this is probably what you're going to do. Similarly, when we do our vestibular test, we are testing at different frequencies and we're able to then understand a form of vestibulogram. So we're testing the vestibulo-ocular reflex, the vestibulospinal reflex, the otolith system and all the central connections. And with that, we are able to now plan what is to be done. So this is the clinical guidelines for vestibular rehabilitation, in which they have said that we need to identify the activity limitation, the area which is affected. The rehabilitation should be supervised, and if patients are giving exercises which are not suitable for their condition, they can actually get worse. So it's very, very important to understand what do we have to do. Just giving, just like Dr. Amit had talked about, giving that list of exercises, telling the patient just do this is not enough. It is not motivating, it will not work, and finally the importance is that they are fearful of activities which can aggravate their dizziness. So what do we really have to do? His Cawthorne-Cookesy exercises which were developed in 1946. So we have learned so much since that time, it's been so long. So these are inadequate because they do not consider the site or the severity or the condition of the patient and do not take even the associated. Does the patient have arthritis? Does the patient have a back problem? Whatever. So what do we need to consider when we take a patient for rehab? How important is age? So age is important, but that does not mean कि आप बोलो कि चक्कर तो age related है. Never. In fact, you have to modify, plan your rehab according to the age or the factors of the patient, because age does not affect improvement. Secondly, the earlier you start, the better is the outcome. But in patients of chronic issues, still the vestibular rehab can still improve their overall function. And if the patient has comorbidities like vestibular migraines or anxiety, these need to be handled as well to be able to get the best of your rehab. And always avoid your vestibular suppressant medicines because they will not allow the compensation to occur. So this was the study done by Michel Lacour, in which he actually did a study with patients who started rehab after vestibular neurectomy on the second day, in the first week versus after 7 weeks. And you can see how different the outcome was in both of these cases. So there are different strategies which we need to work on when we work with our rehab. And if a patient has semicircular canal dysfunction, what we see on our tests, then we will go with a lot of head movements. Never use any restriction of movement or of the neck, because that will again affect your overall recovery. We have to work on gaze stabilization, potentiation of the cervico-ocular reflex, etc. So our rehab will always be progressive. You start with the stage 1, go to level 2, level 3, and it has to be customized according to the requirements of your patients. if the patient has otolith dysfunction, so when you do the SVV, you do the WEMP and you see that the otolith is affected, these patients generally do not complain of spinning, rather of unsteadiness, feeling of rocking, things like that. So we work with rehab on different kinds of surfaces, on foams, on exercise balls, on different kinds of platforms to be able to activate the linear acceleration, the otoliths. And if the patient has vestibulospinal dysfunction, which we check with our craniocorpography, with our posturography, then we work with the ankle and hip strategies and work on giving them alternate stabilization techniques. So when a vestibular deficit is detected, we need to work towards developing new motor patterns which will stimulate the neuroplasticity of the patient. So here I'll just show you how with posturography, we'll be showing you again some of these things in the hands-on workshop as well. So how these different kinds of activities are stimulating the patient to, in a safe, protected environment and also under supervision, but they are now going beyond their limits. By expanding their limits, we are able to stimulate the system and help it recover. Also increase their confidence of how they are able to do it. We work a lot with VR games as well. So, and apps to give the exercises. And over time, we also need to follow these patients up. So you'll see how changes will be seen on VHIT. If initially you get your catch-up saccades which are over, you can see sometimes even naked eye, but with your rehabilitation, the VHIT will show covert saccades. That means the catch-up saccades move closer and closer to the eye movement, which is an indicator of recovery. We can work with our dynamic visual acuity. So this was a patient of vestibular neuritis. Day 1 was, you can see that the VOR was affected here in the gray area. And then with the rehab, after the second visit and then after 6 weeks, come within the normal range. If you can see, even our craniocorpography, over time you can use it as a good monitor of the patients. We're working a lot with virtual reality, in which we can give them a sensation of being in these kind of busy areas, like suppose like a supermarket scene or a library scene. We initially start with very low stimulation, that the patient feels like they're walking through this aisle. And then gradually make it more and more busy, make the aisles narrow, make people walking through, so that when they are actually going to these kind of situations, they don't feel so scared, they feel more confident. We have virtual reality for patients with fear of heights. So they are actually using the VR goggle, they can look around. We always start with a platform which is wider at a lower height, and as they go higher and higher, they can actually look down and then we see how is their sway, their control, all of that to be able to train them better. Okay, so finally, this is our goal. We are working also on developing vestibular rehab to potentiate healthy people as well, and actually doing some studies with athletes, with school children, of how we can improve their vestibular function. Thank you so much.
Both our chairpersons, first Dr. S.S. Kapoor sir and Dr. Mahesh sir, to please. I'd also like to request Dr. Arijit sir to please celebrate our esteemed chairpersons for the
such a complex topic. in a, I think, better way, so that we all need updatation in this field, and I hope continuously organizing such programs.
Because as I personally believe, a balanced diet means a plate in my both hands. The session will resume sharply at 1 p.m. Kindly proceed for lunch.